My name is Jean Arzbaecher. I'm going to be discussing side effects of brain tumor treatment. I would like to thank the American Brain Tumor Association for including me in this webinar. And now my mouse is stuck, I'm sorry. Activity. So I'm going to be speaking about brain tumor treatment and its effects on patients, as well as the management of these effects from the point of view of both the patient being able to self-manage, as well as management from the healthcare provider's perspective. There are 4 major treatment modalities that are part of all brain tumor treatment, and that would be surgery, radiation, chemotherapy, and then supportive medication. And I'm going to cover each of these treatment modalities separately. So the first thing I'm going to speak about is brain tumor surgery. And brain tumor surgery can vary. The goal of surgery is to establish a tissue diagnosis plus the largest safe resection that's possible. Brain tumor surgery is never curative in malignant glioma. So there are several levels of surgery that you can perform. First of all, there's a biopsy, which the purpose of this would be to establish a tissue diagnosis only. So that might be if the brain tumor is in a eloquent area of the brain and the surgeon feels like any further resection may cause the patient more harm. The next is a surgical resection. So there can be a subtotal surgical resection, which is the surgeon removes the part of the brain tumor that he feels is safe to do so, or a gross total resection. What a gross total resection is the surgeon removes every part of the brain tumor that he can see, keeping in mind that there are microscopic cells that the surgeon often can't see, which is why surgery is not curative in these types of tumors. And then there's re-resection. So after patients have had some treatment, oftentimes when they have tumor recurrence or worsening on their MRI scan, it will be discussed whether re-resection makes sense in this case. The major goal, if someone's going to have re-resection, would be reduction in the bulk of the tumor. If the patient is having significant symptoms, signs and symptoms from the mass of the brain tumor, to help relieve some of that mass effect, or to establish a different diagnosis. Perhaps if the patient had a lower grade tumor, a re-resection might identify whether the tumor has progressed to a higher grade tumor. So re-resection is often discussed on a case-by-case basis. There are side effects and complications of brain tumor surgery, which the surgeon will discuss with their patient. The first one is wound infection. Whenever you have any type of surgery, wound infection is always a potential complication, especially if the person has had previous surgeries and previous infections. They tend to be more prone for a wound infection. The next is called a subdural hygroma, and what a hygroma is it's a fluid, there's a fluid accumulation, and it's between the dura, which is the covering of the brain, and the brain itself. So oftentimes this occurs after surgery and doesn't have any symptoms, but something that needs to be watched radiographically. You can also have wound healing complications. So this would be someone whose incision starts to break down or has some oozing from the wound itself. And this is more common if the patient has had previous brain irradiation, because the scalp can be more fragile when someone's had brain radiation. So it might be more difficult for the wound to heal. Then you can have what's called a subgaleal fluid collection, This is a fluid collection that's outside of the skull, and can look in between the skin, and can look like a area of water directly under the skin. And this is common, and usually it's treated by just watching it, and usually the fluid resolves on its own. So the second treatment modality that I'm going to talk about is radiation therapy. The goal of radiation therapy is to destroy or stop brain tumor growth. So the standard of care in brain tumors in regards to radiation therapy is called intensity modulated radiation therapy, or IMRT. This is a computer controlled delivery of radiation therapy that can be very precise. How this works is it has a restriction of the radiation volume to the tumor bed plus a margin outside the tumor bed rather than the entire brain. And what you do is you contour normal structures to be avoided. So it's three-dimensional, and if there are specific structures that you want to avoid, you can direct the computer to guide the radiation beam away from those structures while still being able to provide adequate amounts of radiation to the brain tumor itself. The standard radiotherapy for a newly diagnosed malignant glioma, you give fractionated focal radiation. Fractions are, it's broken up, the radiation is broken up into fractions, and you give 2 gray per day, 5 days a week for 6 weeks. So that's a total of 30 fractions and a total of 60 gray. The fields are expanded to include the high-risk areas. Many studies have demonstrated that more than 80% of failures occur within a 2-centimeter margin of the original tumor. So how they do their radiation planning is they include an area within 2 centimeters of the T2 abnormality, the brain MRI abnormality, in the preoperative scan, because the thought is that within those 2 centimeters of the entire tumor is where you might find the microscopic cells that the surgeon was not able to see and not able to remove. And the question often comes up when someone has tumor recurrence, whether radiation makes sense, whether re-irradiation is an option for that specific patient. Like surgery, every case is individual and has to be looked at on an individual basis. Radiation for recurrence is currently being studied in many different clinical trials. It's often accompanied by the chemotherapy Bevacizumab, which is thought to help protect the brain from the radiation. The regimes in these trials and regimes in care vary depending on the institution or the protocol. It could be hypofractionated, which is less fractions. So you recall in newly diagnosed that there were 30 fractions. This might be 5 or 10 fractions. You can also get stereotactic radiosurgery. Examples of this is linear accelerator, gamma knife, cyber knife. What this does is it delivers high dose of radiation to a small, discrete, well-defined target. Usually what you give for stereotactic radiosurgery is between 18 and 20 gray. The total dose varies for the hypofractionated radiation between 25 and 45 centigrade. There are adverse effects of radiation therapy that are often related to swelling in the brain related to the inflammation of the radiation. One of these is headaches. That's definitely related to swelling, brain swelling. The person can have nausea or vomiting. This can be related to both brain swelling as well as inflammation. So the brain, when the radiation is occurring, the brain is is in an inflamed state, and that can cause nausea and vomiting from the irritation. Somnolence or fatigue is very common during radiation, and I'm going to address fatigue specifically later on in this talk. Someone can have worsening neurological symptoms, once again related to brain swelling, so it's very important for the patient to keep in close contact with their physicians to determine whether steroid medication, which I will discuss later, is indicated in that case. Patients often experience hair loss. Sometimes the hair loss is permanent, although usually hair does start to grow back. When you usually see the majority of the hair loss is at the site of entry of the radiation as well as the site of exit. So the area of the skull opposite where the radiation beam goes in for the tumor, often you'll see an area of hair loss there. You can also have skin irritation from the radiation. It's important to educate patients to discuss skin treatments with the radiation oncology team because there are certain lotions and creams that should be avoided when someone is receiving radiation therapy. And then you can have effects on cognition, and these can be long-term effects. You can see them several years, many, many years after the radiation. And I'm going to talk a little bit about cognitive effects with patients with brain tumors later on in this talk. Then there is a common phenomena called radiation necrosis. And what this is it's due to cell death, both tumor death and brain cell death. Brain cells are able to regenerate after radiation. However, brain tumor cells often cannot. So radiation necrosis is death of one or the other. So it's necrosis within the brain. It may develop months or years after radiation. It's not always related to the tumor dose or the volume of radiation. The difficult thing about radiation necrosis is that it looks similar to brain tumor on an MRI scan. So it shows enhancement, and there's increase in the T2 flare signal. Both of those brain tumors also show those two things. So they look very similar. You can look at MR spectroscopy and PET scanning that can be helpful in differentiating necrosis versus tumor. You also can look at perfusion, brain perfusion, to see if there's increased perfusion, which is more common in brain tumors than radiation necrosis. Oftentimes, a biopsy is indicated when it is unclear whether the patient is experiencing radiation necrosis versus tumor progression, because it would make sense that it's very important to differentiate between necrosis and tumor. If you're giving a treatment, a chemotherapy, and someone has radiation necrosis, and someone has necrosis and not progressing tumor, that's an important distinction to make, so you don't give up a therapy before it's actually has failed. Moving on to the third treatment modality for malignant gliomas is chemotherapy. So there's a standard chemotherapy for malignant gliomas, and I'm going to talk about each of these. Temozolomide or Temodar during and after radiation, which is an oral medication. Bevacizumab, which is approved for when the brain tumor recurs, as well as PCV. There are many other regimes which are considered off-label, which I'm not going to discuss, but there are many regimes that have shown some response in brain tumors, and so those are often tried when a patient has failed all the standard chemotherapy, but I'm not going to discuss the off-label. So the first drug I'm going to talk about is temozolomide or Temodar. The dosing of Temodar is based on your body surface area, which is a formula that you dose it with. The dose is 75 milligrams per meter squared during radiation. So that's something that you take orally every day during radiation, including days that you don't get radiation, like weekends and holidays. So you take this for the entire 6 weeks or 30 fractions of radiation. After the radiation is complete, the patient gets approximately a 3 to 5 week break from both chemotherapy and radiation. And at that point, they start the Temodar cycles. And what a cycle is you get your first cycle is 150 milligrams per meter squared for 5 days of every 28. If the patient tolerates that dose, the next cycle is dosed at 200 milligrams per meter squared for 5 days of every 28. These cycles continue for between 6 to 12 cycles, depending on the patient's response, as well as depending on the MRI scan. There are side effects of the temozolomide medication. One of the most significant side effects is it can cause myelosuppression. So it's very important to monitor the blood counts at week 3 and week 4. There's a term that we use in oncology that's called nadir, and what that means is the lowest point of a cycle. So the lowest point, based on all the research, the lowest point of temozolomide is at 3 weeks. So it's important to obtain a blood count at the 3rd week to determine how low the blood counts are. And then you have to repeat the blood count at the 4th week to make sure that it's safe to proceed with the next cycle of chemotherapy. Nausea and vomiting. This is common with the drug temozolomide if you don't take appropriate anti-nausea medications before the medication. But in the majority of patients, we are able to control nausea and vomiting and eliminate it completely. Fatigue is common during the chemotherapy, and I'm going to address fatigue after I talk about the treatment modalities, because many of the treatment modalities that we discuss can cause a fatigue in the patient. And then constipation. Constipation is a very common complaint among patients that are taking temozolomide, ondansetron, as well as narcotics. So it's something that has to be addressed and should be addressed early so the patient avoids any straining. You can have, the first thing you do teaching with is dietary management of constipation, having the patients focus on high fiber foods, fruits and vegetables with plenty of fluids. They should avoid constipating foods such as cheese and bananas. And then you can also have pharmacological management. So different over-the-counter medications that help promote regular bowel movements should be encouraged if the dietary management is not successful. This is a recipe for, excuse me, something called power pudding, which is a natural thing that we use to help control constipation. And you make this at home and have a quarter of a cup daily, once again followed by a full glass of water. It's important to, as you're increasing fiber, to make sure you're increasing your fluids along with the fiber. But it includes prunes, applesauce, all bran, and prune juice. And many of our patients have had a lot of success with using this recipe in order to control their constipation. The next chemotherapy that we're going to talk about is called Bevacizumab, or Avastin. This is a medication that is given through the IV and is given every 2 weeks. And it is a drug that's approved for when the tumor has recurred. So it's approved for recurrent malignant gliomas. There are many side effects that people need to watch for, as well as patients need to be educated about, of the drug bevacizumab. One is hypertension. Many studies have shown that patients develop hypertension when they receive bevacizumab, especially patients in the brain tumor population. So it's important to for the patient to have get well-controlled blood pressure in order to safely continue to receive bevacizumab. In my practice, I have never had a patient that we haven't been able to control their blood pressure with oral medications while they're on bevacizumab, but it is common to see hypertension with this medication. And then bleeding. So what bevacizumab does is it blocks something called vascular endothelial growth factor, which is a substance that tumors put out that encourage blood vessel formation, and it blocks that. So you can see bleeding on patients on bevacizumab. Nosebleeds, we see these commonly, especially in wintertime, in Chicago especially. So they may have nosebleeds. They can have rectal bleedings. Oftentimes people who have discover that they have hemorrhoids when they're on bevacizumab because they start to have rectal bleeding or hemorrhoidal bleeding. They can also have bleeding into the tumor, and this is a serious complication that can occur with bevacizumab. In the studies, there was not evidence that there was an increased risk of bleeding into the tumor, but it's always a potential side effect. Also, you can have protein in the urine or nephrotic syndrome or problems with your kidneys from bevacizumab. So this needs to be monitored. So monitoring the urine for protein, spilling of protein, is important routinely when a patient receives bevacizumab in order to pick up a problem before the situation gets more severe. There can be fistulas or GI perforations as a complication of bevacizumab. So if patients begin to complain of abdominal pain, this should be addressed. And then oftentimes the patient gets a hoarse voice, and this stays on through the course of the bevacizumab. So it's important to educate patients that this is common, that their voice may change if they're on this medication. And then I'm going to talk about PCV, which is a combination of chemotherapies that are given for brain tumors. The P stands for Procarbazine, the C for CCNU, and the V for Vincristine. So it's a combination of 3 medications that are given. This is an old regime that was approved many, many years ago. And with the introduction of Temozolomide, many practitioners choose Temozolomide over PCV because of its side effect profile is less. However, in recurrence, this is often used, or with people with certain types of tumors, this regime is gaining favor again. Vincristine is often not included because it doesn't penetrate the blood-brain barrier, and there are very significant neuropathic side effects of Vincristine. So oftentimes physicians will start with just the P and the C and save the Vincristine for perhaps a later time or perhaps not at all. There are several different regimes for PCV that include the drug Procarbazine. One regime has it at, once again, it's based on body surface area, and one regime has it at 100 milligrams per meter squared, days 1 through 10. Another one has 60 milligrams per meter squared, days 8 through 21. Lomustine, or CCNU, is dosed at 100 milligrams per meter squared on day 1. And the Vincristine is 1.5 milligrams per meter squared, a maximum of 2 milligrams for any patient on days 8 and 29. Side effects of PCV, Vincristine, I mentioned it, you can develop significant peripheral neuropathy, which often requires dose discontinuation. And the neuropathy takes a long time, often several years, to improve after dose discontinuation. CCNU, or lomustine, it is a highly emetogenic medication, and what that means is that it can cause nausea and vomiting. So it's very important to give adequate anti-nausea medication before the PCV, as well as the 24 to 48 hours after the CCNU. It also can have a significant suppression of your bone marrow. So the nadir, I talked about the lowest point of the CCNU, the nadir of CCNU is 4 weeks. And then the bone marrow usually recovers at 6 weeks. So that's why this is, PCV is dosed on a 6-week schedule. And then the dose has to be reduced if the blood counts are low and stay low at the end of the 6 weeks. And then procarbazine can also cause bone marrow suppression, and there are many dietary restrictions on patients with on procarbazine, and I'm going to get to that. The foods you have to avoid are foods with tyramine, and so the foods that you have to avoid is all aged, natural and aged cheeses, smoked, pickled, or processed meats, so that includes your bolognas, your salamis, all processed meats, soy sauce, overripe fruit and vegetables, red wine, and excessive amounts of chocolate and coffee. And this is important to do education with your patient regarding the tyramine-free diet, because the patient can have a reaction because the procarbazine will interact with the tyramine. So it's important for the patient to follow the procarbazine diet during the while taking the procarbazine, as well as a few days before and a few days after the procarbazine. Very important to make sure that you stress this with your patient. Moving on now to supportive medications that we give to many patients with brain tumors. I'm going to discuss dexamethasone for cerebral edema later when I talk about cerebral edema. And then I'm going to talk about anti-epileptic medications. So seizures. Seizures are very common during brain tumor illness. 20% of patients will present with a seizure at diagnosis, and 50% of people with brain tumors will seize at some point during their illness. The seizures are caused by cortical irritation, tumor, edema, or response to treatment, scar tissue, or medication withdrawal. And the postictal state, postictal meaning the period after the seizure, patients may have neurological deficits that persist longer than normal. This is a phenomenon called Todd's phenomena, and many brain tumor symptoms get worse for a length of time after a seizure. The American Academy of Neurology has made recommendations that patients should be put on seizure medication only if they've had a seizure in their brain tumor illness. But this is always something that should be discussed with your patient as far as whether or not to prophylact for seizures, and how long a patient should be on an anti-epileptic medication is variable, and there's still studies out. They're still studying that. So there are many different types of seizures, and so it's important to differentiate what types of seizures the patient may experience. Generalized seizures, these are in the past used to be called grand mal seizures. These can be tonic, clonic, or tonic and clonic. So usually the patient loses consciousness during these types of seizures. Partial seizures, there's localized activity. There may be hallucinations or autonomic activity or bizarre activity. When someone has seizures in their temporal lobe, they may have abnormal smells or abnormal feelings or abnormal behaviors as part of their seizure disease. A mixed seizure can be any combination of generalized and partial. And then there's something called status epilepticus. That's life-threatening, and it's when a second seizure occurs without recovery from the first or lasting longer than 30 minutes. Seizure management. So what do? You know, this is support group, a support group discussion webinar, and probably a common thing to have someone have a seizure during a support group or even in the home. So the first thing, the most important thing that you need to do is remain calm. And then you want to prevent the patient from injuring themselves. So move harmful objects, but do not try to restrain the patient. So if they're near furniture, remove the furniture, but don't try to hold the person down or restrict the movements. Keep onlookers away. It's very important for the patient when he recovers from his seizure to not wake up and have many strangers staring at him. So make sure to keep onlookers away so the patient can have some privacy when they recover. Don't ever try to put anything in the mouth. This can cause major injury to teeth and jaws. You can turn them on their side. If the seizure lasts longer than 2 minutes, you should call the paramedics. And the most important thing is be sensitive and supportive, because seizures are a frightening experience for both the person experiencing the seizure and the loved ones, the caregivers of that person. So use of anti-epileptic medication in patients who've never had a seizure is controversial. I mentioned that previously. Many of the frontline anti-epileptic drugs have interactions with other medications that are common in brain tumor patients, including warfarin or Coumadin if someone has a blood clot, chemotherapy, and antibiotics. Side effects of anti-epileptic medications: you can develop a rash, which would then determine that you have an allergy to that medication. Bone marrow suppression or neutropenia. And again, if a patient is also receiving chemotherapy, the bone marrow suppression is more of a concern. Drowsiness. And then you can have personality changes. And there are phenomena out there on the internet that patients have named. Keprage. There's patients who say when they take Keppra, they get angry and have outbursts. Or Dopamax. I've heard on other patient blogs, etc., just that maybe the topiramate or Topamax might make them a little bit drowsy. Now we're going to talk about cerebral edema, or swelling in the brain. This can occur perioperative, so during the operation and in the immediate postoperative state. It can occur during radiation. That's the most common time for it to occur. It occurs in recurrence, so when the tumor has started to grow again, there's cerebral edema. And it's evidenced by headache and focal neurological deficits. How do we manage it? Corticosteroids or dexamethasone to reduce the peritumoral and vasogenic brain edema. Bevacizumab is also effective in reducing cerebral edema. And the response is measured in terms of improvement in neurological deficits within 48 hours. The usual time frame is between 4 and 24 hours. Adverse effects of dexamethasone: behavior and mood changes. Oftentimes patients on steroids have difficulty sleeping and have behavior. They might have labile behavior, crying 1 minute, laughing the next minute. They can have weight gain, moon phases, and fluid retention. Hyperglycemia or development of diabetes. Gastritis or GI bleeding or GI distress. With long-term use, you can have osteoporosis. And then steroid myopathy. Steroid myopathy is a weakness that develops, and it's important to differentiate steroid myopathy from progressive neurological worsening. Weakness occurs primarily in the proximal muscles of the upper and lower extremities. The effects can be quite disabling, and it manifests as trouble combing your hair, getting out of a chair, or walking upstairs. Managing the adverse effects: continuing attempts at decreasing or eliminating the dosage. It's important for the patient to be on the least amount of dose that will control the brain tumor swelling symptoms. Therapy must be tapered because of its interaction with the hypothalamic pituitary adrenal cortical, or the HPA axis. So the body stops making its own cortisol when it has had some exposure to dexamethasone. So it's important for you to taper the therapy so the body can start to naturally produce the cortisol again. Sometimes you need physical or occupational therapy if the patient has steroid myopathy. Watch the blood sugars in an at-risk patient, and then just education about steroids and their uses and their effects. Headache is a common problem during brain tumor illness. 35% have a headache at diagnosis, and 70% have a headache sometime during their illness. It is the most distressing symptom by patient report. Headache management is often dependent on the etiology. Dexamethasone, adding or adjusting the dose if mass effect is seen on the MRI scan, and once again, wean when possible. Anti-inflammatory medications if they're not contraindicated in the patient. Migraine preparations, biofeedback or relaxation technique, and then there's off-label medications. There's different, there's antidepressants such as amitriptyline or anti-epileptic medications such as topiramate that are all often very effective in managing headaches. Fatigue. Fatigue is a very common complaint amongst brain tumor patients and long-term survivors. It is one of the most debilitating yet least understood effects of brain tumors. It is often not addressed by the healthcare team, but has a major impact on quality of life. It's different from the fatigue of everyday life, which is usually temporary and relieved by rest. The occurrence of fatigue, it may be caused by the brain injury that was incurred from the tumor or the treatment, but its occurrence can also be unpredictable. It can occur in both benign and malignant tumors and can occur throughout treatment, most prominently during and immediately after radiation. However, we did a study of long-term survivors of brain tumors, people who have had malignant gliomas for longer than 3 years. And fatigue was very common in people, even several years out of brain tumor diagnosis and several years off of treatment. So this is definitely something that needs to be addressed. Contributing factors, surgery, radiation therapy, usually about halfway through the 6-week radiation is when you start to feel fatigued, and that fatigue doesn't necessarily dissipate as soon as the radiation is complete. Chemotherapy can add to fatigue, medications, tumor presence, tumor cell destruction, as well as the emotional impact of the diagnosis. Other possible causes, anemia, infection, depression, sleep abnormalities, or dietary changes. So it's important to assist the survivor to manage the fatigue. Number one is treat the medical cause. If someone has anemia or someone has an infection, that needs to be treated in order to assist with managing the fatigue. Energy conservation, so if someone is in the middle of radiation, it's important for them to conserve their energy and control and plan things, activities throughout the day. Use of assistive devices, so canes, wheelchairs, walkers, in order to help the survivor to manage. Adequate sleep and rest. It's very important for people with brain tumors to develop a schedule of sleep and rest and to maintain that schedule. Listen to their body. If their body tells them to rest, they need to rest. Proper nutrition is important in managing the fatigue. And if all these things do not work, there are medications such as methylphenidate or modafinil that can be tried. One of the most important things that you can do in order to assist with fatigue is physical activity. Studies suggest that cancer patients who engage in at least 3 to 5 hours of activity per week may have less fatigue. Studies also suggest that physical activity may improve overall survival in cancer. Exercise promotes a healthy body and helps reduce psychological stress. And the timing of the physical activity. It's important to listen to your body and time your physical activity around your points of least fatigue. The final thing I'm going to talk about is behavior and mood changes. Many brain tumor survivors face changes in memory, thinking, or emotions. It is estimated that more than half of all patients with malignant brain tumors experience some cognitive or behavior change at some point in their disease. The changes may be so subtle that the patients themselves are more aware of their difficulties than those around them. Other times, it's the caregiver rather than the patient who first sees the difference in behavior and mood. Causes of behavior and mood changes. There can be factors associated with the tumor, for instance, its location, the size, and the rate of growth, the psychological implications of the tumor, and then interventions used to treat the tumor. Radiation, especially children and the elderly, radiation can cause cognitive deficits that are long-standing. Surgery and chemotherapy. In patients without brain tumors who receive chemotherapies for other types of cancer, there's a phenomenon called chemobrain. And what that is someone who's got another type of cancer develops a fogginess or a behavior or mood change that that impairs their memory and their thinking. And patients with brain tumors are receiving chemotherapy and have an injury to their brain, so the effects can be larger. Common difficulties that we see in people with malignant gliomas in relation to behavior and mood changes. We can see language problems, so sometimes someone with a problem expressing themselves is seen as confused. However, what they really have is a difficulty with their speech. Attention, so oftentimes it's hard to concentrate on more than one thing. Concentration, so it's very difficult sometimes for someone who's had a brain tumor to multitask, to be able to attend and concentrate on more than one thing. So in the past, if they used to be able to make dinner and help their children with their homework and watch the news, maybe they can only do one of those things at a time. It's difficult to multitask. It's sometimes difficult to learn new things. Memory can be affected. Usually the short-term memory is affected before the long-term memory. General intellectual abilities, so ability to balance checkbooks or do your computations if your job requires that. General intellectual abilities can be decreased. Emotions, so someone can have labile emotions, and then depression, and we're going to talk about depression a little bit more. Treatment of behavior and mood changes. I think the most important thing is to recognize the symptoms, recognize them, discuss them with the healthcare provider, and be able to identify their relationship to the brain tumor. Discuss it with the healthcare team. It's important for caregivers to be involved in this aspect, so the healthcare team is aware of behavior and mood changes that the caregivers are witnessing. Formal neuropsychological testing, that can be very helpful to see where people's strengths and weaknesses are in relationship to your cognitive abilities. So someone might find from neurocognitive testing that someone's visual ability is less impaired. So maybe if you can see something or read something, that might make it easier. But just to get an idea of where the deficits are and how to best compensate for them. Counseling and psychotherapy can be very helpful to help cope with the deficits, as well as come up with strategies in order to manage the deficits. Support groups, this is a support group webinar. I can't say enough about the importance of support groups in helping people realize that they're not alone in their cognitive abilities and disabilities. Medications to help maintain focus. And then cognitive rehab. This can be done by either a psychologist or a speech therapist, where you work on the areas of deficit and see, help people to promote as much of their independence as they're able to. And then speaking about depression, clinically important depression is a common complication in patients with high-grade glioma. The prevalence has been shown to be between 15 and 38%. It's difficult to differentiate which of the depressive symptoms are caused by the neuropsychological effects of the tumor and which are the patient's psychological reactions to the stress caused by serious disease. Depression has a significant effect on functional outcome and quality of life. So it's important to identify depression and to perhaps initiate treatment for it. Treatment can be, excuse me, treatment can be pharmacological intervention with antidepressant medications, active psychotherapy, counseling, and again, support groups. And then just finishing up with compensatory techniques. There are many compensatory techniques that people with brain tumors who are experiencing behavior changes can do in order to help them be functionally independent. One of them is to organize the environment. So it's important to remove clutter and to organize things in a obvious manner and to keep things in their same place. So if someone is prone to lose their keys, always know that your keys are always put in a certain place, or that your phone is always in a certain place, so you can organize your environment in order to help remember things. Reducing distractions. So if you have to focus on something, remove other stimulus. So don't try to do something while the television's on or while someone's talking to you. If you're someone who works, if you're able to shut your door or turn the music off in order to just be able to focus on what you need to focus on. Checklists, notes, and calendars. I think breaking things down into smaller tasks, into smaller parts, and then keeping track, having notes to yourself as far as lists of what you have to get done. And that should help in everyday life. Reminder alarms for medications and appointments. So now with the, in the technology that we're at, setting your cell phone for, 10 minutes before an appointment or when it's time to take your medication, so you're able to remember it. Trying to avoid fatigue in the other ways, because when someone is fatigued, they're not as able to concentrate. And then prioritize and pace activities. So that would be being able to decide what's important as part of the fatigue. Decide what tasks you have to finish and prioritize them and do those first. That is the end of my discussion. Thank you for your attendance, and if there are any questions, I'm happy to answer them. Thank you.